Hi everyone, my name is Laura Baskall-Smith from SLP Mommy of Apraxia, and I am just blown away, thrilled. There's really no words to describe how honored I am that 3 of the top esteemed researchers in childhood apraxia speech agreed to take their free time and do a Zoom to go over recent papers, and I'm just so thankful. So I'm going to have them all introduce themselves. They're all going to talk about some recent work that they've put out lately. And so, John, I'm going to start with you.
Okay, I'm John Preston. I am an associate professor at Syracuse University in the Department of Communication Sciences and Disorders. I am a licensed speech pathologist. I started as an SLP in the schools and then transitioned into research. And right now I'm doing research on working with school-age children with persisting speech problems with CAS.
I didn't know you were a school speech therapist to start with. Wow.
Yeah, ages ago.
Yes, I'm sure it feels.
I miss it.
Ruth.
Okay, I started my life as a school SLP as well. Transitioned to Mayo Clinic quite a few years ago. And so I've been primarily a clinician all my life, but later in life went back for a PhD and was able to become a hanger-on with researchers. I wouldn't say I'm a top researcher, but I'm a top interest in research person.
Whatever. Dr. Stoeckel, yes, you are.
Well, I do like to teach, and so I enjoy being able to do boot camp and those kinds of workshops and things.
Yeah, I should let people know that Ruth was my main mentor at the Apraxia Kids Boot Camp. So we had 3, and we were broken up into separate groups and had, one kind of point of contact. And so Ruth was mine, and now she's stuck with me because I never stopped messaging her after that. So thank you. And Jenya.
I'm Jenya Iuzzini-Seigel, and I'm an assistant professor in the Department of Speech Pathology and Audiology at Marquette University in Milwaukee. I started out working in hospitals and was starting my PhD program at that time, and then ended up in academia, and I love it. My research focuses on diagnosis and treatment of childhood apraxia of speech, and I'm very much interested in care of the whole child. So we'll talk a little bit more about that when we get to my.
What got you into being interested in CAS specifically after working at a hospital setting?
I was sort of doing it simultaneously because when I started my master's degree at Indiana University, I was working with Dr. Karen Forrest, and she was working on a treatment study looking at the effects of oral motor therapy on speech sound production. And so we know how that research ended up, oral motor therapy. But anyway, so we were working with children with childhood apraxia of speech, and it just seemed like such an interesting disorder. So I ended up doing my dissertation on it. And the hospital that I was working at was a small rural kind of hospital. So I was seeing everybody, children, adults, motor speech, phonological everything. And it was really interesting. I kind of love that experience.
Yeah. Wow, thank you. All right, so for the purpose of today's talk, what I thought I'd do is all these researchers have recently published papers. I'm the one that chose what papers that I wanted them to discuss today. And the first one I'm going to go to is Dr. Preston's paper, and the one I wanted him to do is a tutorial, and it's speech motor chaining treatment for school-age children with speech sound disorders. And the reason I chose it is because it has a lot of resources for SLPs that he included. One kind of this graph that you can get online, or not graph, but this data collection chart that you can get online. And I think it's really good for speech therapists to start looking at residual speech sound errors from even just a motor planning, principles of motor planning treatment, because it's in the research demonstrating to be highly effective. And every speech therapist I know practically hates those residual errors. So Dr. Preston, if you could just give a brief overview.
Yeah, so the tutorial is on a procedure that we developed probably started in maybe 2012 or so, and it's kind of evolved over the years, like most treatments do. But it's really just a structured way of trying to implement several of the principles of motor learning. But it's really designed to try to sequence from a focus on principles of acquisition to a focus on principles of motor learning. So if you kind of throw a child right into, a motor learning approach and they don't have any skill to begin with, they're likely to fail. So it's really designed to kind of go through sort of some baby steps to get from, accuracy on relatively simple targets and to try to progress to much more complicated targets as quickly as the child can. Chaining is the concept of building around a core movement. So, and we use the core movement as essentially a syllable. So for each child, we select core syllables that are difficult for them that may include those difficult later sounds like R's and L's and S's and velar sounds. But we've also used it with school-age kids who have persisting errors on T and D and N, the general concept is the same, is that you're starting with a syllable and then you add a little bit to it when the child is successful. And if they're successful there, you add a little bit more to it and then you just continue to grow from there. So for example, if you're starting with a core syllable like key, you can add a little bit more to it if the child is successful to build to a word like keep. Then you can add more to it to a word like, to get to a word like keeping. Then you can build it to a phrase like she is keeping. And then you can just have the child make up a sentence with keeping in it. So structuring treatment that way sort of guarantees that when the child gets to the next level, they've already had success on a smaller unit. So when the child's practicing keeping, they've already been successful on the word keep, and they wouldn't get up to that, to a multisyllabic word if they can't successfully produce the monosyllabic word.
Right.
So we've developed a data sheet that includes a lot of examples of these already in it. There's an Excel document that's freely available that people can download that has hundreds of examples that build around this structure here. And so children essentially progress from through these 5 levels of practice. And as they're progressing to more complicated targets, we're also changing some factors like how much feedback we're giving them. And so to go along with some of the principles of motor learning, we're gradually reducing the frequency of feedback from being very supportive to being much less supportive, and changing from primarily giving knowledge of performance feedback early on syllables to primarily just knowledge of results feedback later on at phrases and sentences. We incorporate some factors like variability of practice in chaining as well. And one of the simplest ways to do that, which you don't have to do with chaining, you can do with anything, but we start to introduce prosodic variation by having kids practice words louder, softer, faster, slower, with rising intonation like it's a question, or say it like it's a command or a statement. That's a way to help kids try to integrate some of the supralaryngeal articulatory movements with some of the respiratory and the phonatory requirements of varying prosody. So,
and also that helps with generalization, right?
So we had a study in 2017 where we looked specifically at that practice variability component, and having kids practice by varying prosody of a target did result in faster learning for all the kids in the study.
Yeah, I really like your data collection sheet because, or even this article in general, because all of us kind of, every one of us would probably say if a therapist comes to us and wants to know more about principles of motor learning, we shoot them over to the Moss article and say, this is where you need to start. And that is where they need to start. But what I like is that you do give a good general overview of a lot of principles of motor learning while you're just discussing this chaining in general. And what's really nice from a clinician perspective is that the data collection sheet kind of directly shows how you're going to do it. And so I can tell you just from a clinician working with this, like, you know, he's got on here, I just did it with a kid today, kind of like with a trial who has a residual R, so I started it, but I really, you know what I wasn't doing a lot is having them, there's a box on here for them to monitor themselves, and then I say whether I agree or disagree. And I have, you know, many times in therapy completely forgotten, especially when they're older. You know, I'm talking about an 8-year-old. He's totally able to monitor himself now.
Yeah, and that's a good point, that this is really designed for those older school age kids. I mean, this is not something you're going to do with the 3 or 4-year-old with CAS probably. We've tried it primarily with about ages 7 and up.
Yeah.
So yeah, the kid that you were working with would likely be a good candidate for something like this.
Yeah. So anyway, I really encourage people to check out his article online. There's the links to the Excel document. It's very easy to fill out. It's drop down boxes. There's like an 8-minute tutorial. Did a colleague of yours do that?
So we have 2 videos up there. One is sort of how to use the data sheet, and the other is an example of a treatment session where someone is actually using the data sheet and you're hearing the child progress through the treatment. So yeah, that was me and my co-authors, Megan Leese and Jackie Storto, put all that together.
Yeah, it's so great. So I hope people really check that out. Thank you so much. And I just want to clarify, what population would you recommend? It's school age, but you're talking about, it's not just children with CAS that you would recommend this for.
So we've used it for kids with CAS and for children with residual articulation errors as well. Yeah.
Right. Yeah, I actually get a decent amount of questions from therapists asking, okay, I have CAS in the history, and now they have these residual issues. What am I supposed to do?
Yeah. And that's kind of who this was designed for. There are other approaches for some of these older kids. This isn't the only thing that should be on your plate, right? I mean, there's REST out there, for example, which does a really good job of addressing prosodic deficits too. So I would say this should be maybe one tool in your toolbox.
Yeah, which is why I'm excited to do this, because Dr. Stoeckel will talk about that at the end. She has, in her Perspectives article, she discusses some different ways of problem solving, what approach to use and why. And one of them includes a child with a residual, articulation errors. So thank you so much. Okay, I'm assuming that are you willing to have people, email you with any questions? Is there an
Absolutely.
Yep.
Yep. My email is jopresto@syr.edu.
Awesome. Thank you so much. I have to tell you, for my audience, Dr. Preston has a toddler and he is trying to juggle that, as we all are. And so they're doing this very late at night with me. And I just really appreciate you coming on to give this information. I just
realized it's dark outside here, but you guys are further west, and so the sun has not yet set there.
Yeah. Oh yeah. No, my child wants to be a dog walker, and when I get done with this, I'm gonna have to hightail it out to the park. So take the dog for a walk. Okay. So Jenya, I'm gonna move to your paper. And your paper that I wanted you to discuss was motor performance in children with childhood apraxia of speech and speech sound disorders. And the reason I loved this paper was because most of you know my child has childhood apraxia of speech, but she also has a genetic mutation called BCL11A that caused a bunch of different issues. And one of them was developmental coordination disorder. And if people don't know about CAS, they know even less about dyspraxia and developmental coordination disorder. And so I was really excited to see a researcher, like you just said when you introed yourself, that makes total sense. Your interest is looking at the whole child. And that's why I was in love with this article. So my favorite color is purple, and it's just, you probably can't tell, but it's just purpled up here. I basically underlined almost everything, but I do want to hear you give a brief overview of this article, please.
So I became interested in this idea of the care of the whole child, really like during my doctoral work, and then even more so in my postdoc. I remember having some children in for this assessment study we were doing, and if they would start to get a little rambunctious because they were getting bored doing the assessment, I would say like, oh, give me 10 jumping jacks or something like that, just to get them to burn a little energy. And I just so vividly remember this child who was probably about 10 years old doing these jumping jacks, and they were so discoordinated. And his mom was sitting there, and I just kind of looked up at the mom, and she was just like, can you even believe, what you're seeing right now?
I have a kid like that. Yep.
This is so interesting. I mean, it's really easy to see, you know, if a child walks in, maybe their gait's a little different or something like that, but it was just really profound. So anyway, that kind of stuck in my head, and I just thought I really want to dig into that more, and I was really excited to get going with it with this paper. So we looked at 10 children with childhood apraxia of speech and then 30 controls, I believe. The kids were a little like close to 4 years old up till I think about 10 years old, and or a little younger, maybe 9. And we gave them a variety of assessments, so really thorough speech testing, language testing, like we always do. And then we also did the movement ABC, the movement assessment battery for children. This motor assessment we chose because it's very sensitive in identifying even mild impairments. And it's also been tested and shown good validity for assessing children with a range of cognitive linguistic abilities. So that was really important because the children that come into my lab really run the gamut in terms of what we see. A lot of the kids in the study actually had receptive language impairments too, in addition to the expressive language impairment that the majority of our kids tend to have. So it was important that the tool that we were using was going to be valid in those different populations. And what we found was that the children with CAS really did perform quite poorly on this assessment battery. And the kinds of tasks that it has them do are aiming and catching, balance, so they're standing on, you know, each leg, they're hopping, they're jumping, they're doing aiming and catching kinds of tasks, manual dexterity tasks where they're doing threading a lace, you know, through some holes, or trying to track a trail with a pen, you know, without picking a pen up, those kinds of things. And the kids with apraxia did quite poorly on the balance and the aiming and catching tasks. And they actually did well on the, you know, maybe not super well, but better on the manual dexterity tasks, which I was kind of surprised about. I was expecting that those would have been more poor. So I thought that was interesting. And we looked at them in comparison to children with speech sound disorders, like phonological disorder, autic disorder, mostly phonological, and then also kids with SSD plus language impairments, and then also typically developing children. Some of the findings that I thought were particularly interesting was that of the children with CAS, I believe 7 out of 7 of the kids who had CAS plus language impairment performed, like showed significant movement difficulty on this assessment. But not all of them had previously had any kind of PT or OT or even a PT eval. But what is also interesting is that their parents reported in the case histories that they did think that their child had a motor problem.
Yes.
So I was just like, my gosh, it's just really amazing to see this gap where the parent is concerned, the child is very clearly demonstrating, you know, deficits, and they've not had, you know, a physical therapy or occupational therapy assessment. So I really look forward to kind of digging into that more in the future as well, to see what happens. Is it that the pediatrician sort of says, well, they're meeting the milestones, you know, maybe they're a little bit late, but they're meeting them. It's not this kid's biggest problem, you know, they have such a significant speech impairment. Or is it that the parent kind of gets overwhelmed and it's easy to kind of not follow up on every single thing that your, you know, doctor tells you to do, or to push it off, and then before you know it, it kind of, you know, disappears into the ether. But I know my son, who's 12 months, he was very late in crawling, and he was a very big boy. And so the pediatrician was like, you don't need to, you know, bring him in for PT. It's fine. You know, he might just be one of those kids that go straight to walking or something. And I was like, well, I don't know about that. I think it's important enough. We're going to.
You know who I am? No, I'm just kidding.
So, I mean, you know, not that my pediatrician's not conscientious, but I really kind of had to, you know, push for that a little bit. And the PT, of course, was like, oh, absolutely. He's like on a, you know, 3-month level. And this was like at 9 or 10 months. So I thought, oh my goodness, you know, like, why would he not get the therapy that he needed? And so I just really think, you know, from this, I feel like as speech pathologists, we should definitely be advocating for kids and making the referrals if we see that a child, you know, if there is a concern by the parents, if we are noticing anything, we should be making those referrals so that the kid gets, you know, total appropriate care.
That's why this research article is so important to me for SLPs to know about, because that's exactly why. Basically, parents are relying on child find, and if you don't qualify for an educational motor-based disorder, you know, well, it's fine. He can navigate his academic realm just fine, but then they're not getting picked up by, you know, private therapists like I feel like they should be now doing this. And I can just remember this one time I had this girl and I wasn't really concerned about her motor at all. Like, she picked a hand, she had a tripod grasp. I mean, I didn't evaluate her, obviously. She seemed fine in that way. That was what I'm saying. But she always fell off her chair, like always fell off her chair. And so I told her mom, I was like, you know what, let's just rule this out. Like, I don't know why she keeps falling off her chair, but I just want to make sure. She was in the 2nd percentile and I wasn't even concerned. I mean, I was shocked that she was in the 2nd percentile. But that's why if the more therapists who know about research like this and know that this can be a common comorbidity, they can be because a lot of parents, they initially, speech is always like the first issue. I feel like that's found a lot of the time. So my big thing in what I write is like, you know, unfortunately, apraxia is just alluding to future issues, unfortunately. And I hate saying that too, because I have a child with it, but it's like the CAS is what gets picked up first a lot of times.
Right.
Go ahead. I wanted to get to Ruth, but I also am super interested in you just talking about the procedural learning deficit hypothesis. I know you could probably spend hours on this, but for those, there's people out there who haven't even heard of that. So can you just briefly explain that?
Sure. So procedural learning is a system by which we learn patterns without being explicitly taught. So the way that we acquire grammatical rules, the way that we acquire speech sounds without, you know, explicit training during, you know, normal, typical development, the way that we learn to ride a bike, all of these things sort of rely on procedural learning ability. So I've started to investigate this in children with apraxia because it is one of those things that can underlie so many modalities. It underlies, you know, the linguistic system, the speech system, the motor system. And when we see that children with CAS have these multi-domain deficits, I'm interested in what could possibly be tying that together. And this procedural learning deficit hypothesis has been used to tie together cognitive, linguistic, and motor deficits in children with dyslexia, with specific language impairment, and developmental coordination disorder. So I think that this is also something that can tie these things together in kids with CAS. And my preliminary work shows that children with CAS and language impairment do evidence poorer procedural learning abilities compared to kids with CAS only and compared to those with, you know, speech delay and typical development as well. What I think is so exciting about this work is that if we find, you know, as we scale this bigger and find it in more children, this could really be sort of a missing piece in terms of why kids with CAS really require such intensive and frequent therapy.
Yeah.
And the explanation would be that they require just many more exposures to a sequence to learn that sequence and to retain that sequence. So if a kid is really requiring this like training of a sequence, speech sounds, you know, sequences, and they, you know, need it daily or every other day, but we're providing treatment like every 3rd day or every 4th day, just based on, you know, what your treatment schedule is, then it could be that like every time that you bring the kid in and they start to show a little bit of progress, they're not going to be able to retain that. That's just not, you know, that might not be like how they're wired for now. And so it could be, you know, as easy as like shifting so that you make sure that they are coming every other day to treatment. And maybe that will help them to really show, you know, much more significant learning and retention. So well, that, you know, remains to be seen. But
yeah. It's just really interesting.
Thank you.
Is there a place that, do you have an email address that you'd be willing to have people reach you at?
I do, but it's like a mouthful.
So long.
I want to just like link to it after.
Yeah, I'll link to it. Thank you. I know I'm worried about saying your name, so I'm actively avoiding it.
Oh, Iuzzini-Seigel.
Okay, we have Ruth, 7 more minutes for you to give, you just had an article in Perspectives with Sue Kaspari, and it was called Childhood Apraxia Speech, Clinical Decision-Making from a Motor-Based Perspective. So I really like this too for similar reasons that I liked Dr. Preston's, was because I think that if the more that therapists get on to learning about motor-based treatments, the better clinicians we're gonna be. So anyway, go ahead and speak to your article.
What we did was we divided it up. We had a younger child with questionable early diagnosis that I saw, and an older child that Sue saw. And we wanted to sort of walk through, you know, like what Jenya says, you want to look at the whole child. And we didn't go into motor and literacy and those things because what was supposed to be like a 4-page paper turned into a much longer issue. But to kind of talk through the thought process of, you don't jump on the diagnosis. If it walks like a duck and quacks like a duck, it's probably a duck, it's not a goose, you know, or if you hear hoofbeats, you think horses before you think. Don't jump on apraxia the minute you see a very young child not talking, but begin to amass your evidence to make that differential diagnosis over time. But there are things you can do, and there is research to guide you. So like I said, I'm a hanger-on with research studies more than that, but very excited to be able to use information that's out there to guide my thinking. So the tutorial on nonverbal children who are not yet imitating, there are techniques, and it talks about what you can do and why you should do it and what the evidence is. You know, and then as you move further along in your decision making about diagnosis and treatment, about how do you begin to incorporate some motor learning into, even with a very young child, how do you be intentional about incorporating that, and how do you extend it? I think one of the things I've found in working with young children is parents and some clinicians are really amazed at how much work you can get out of a 2.5 or 3-year-old child if you just expect them to do it and you make it fun enough, you know, and you're willing to be foolish a little bit, or to follow their lead as terms of interests, but say, okay, you can play with this toy if you do this 5 times. Oh wait, let's do it 6 times, you know, and play the game with them, and, you know, use your behavior mod strategies a little bit. So, and we wanted to point out that even once a diagnosis is made, there's no single intervention that is known to be the answer for every child and for every stage of therapy. So in the young child, we talked about, you know, moving through, I was asked about stimulability therapy. Well, this was a child who was not very cooperative, so stimulability therapy was not the way to go, because you're supposed to be willing to cooperate and do things. Do we incorporate some phonological type stuff? Sure. So you're individualizing to the child. And then for the older child is, well, or I should say adolescent, she was 13. She came in originally to confirm the diagnosis, and Sue worked through, she used the DEMS even though it's intended for younger, more severe children, because it gave her information about motor learning. She wasn't relying on a score on a test. She was relying on observations and clinical judgment. And so she tried to talk through in that older child case study about how you use your clinical thinking skills more than relying on test scores or a recipe for treatment to guide what you're doing. And she introduced REST, and we've talked a couple of times about how this, you know, unfortunately the tutorial that wasn't out at the time, she did that, but, you know, thinking about you're providing treatment, when you talk about evidence-based treatment, it doesn't mean you find the treatment that has the most evidence and apply it. It means you think about what evidence is out there and how it applies to what you're doing. Mm-hmm. So, you know, REST has some research studies. Speech motor chaining doesn't, but they both employ motor techniques that we know are important to making progress. Mm-hmm. So it's making those kinds of judgments about what is working for the child, what's working for the clinician in their knowledge base, and expanding your knowledge base as you work with the child so you're staying abreast of what's going on. So
yes. Sorry, I thought Dr. Preston was going to jump in on something, but did you have something to say? It looked like you did.
I think I was just going to try to clarify that the evidence for chaining has been the base treatment that we're using along with our biofeedback.
Yeah.
So in all of our sessions, kids get chaining in addition to biofeedback, and the only evidence we have for chaining all by itself is not for kids with CAS. It's just for kids with artic errors right now.
Yeah, but it's meaningful for kids with CAS, and that's the point. You know?
Right.
Mm-hmm. Yeah, so I think too, I think it's interesting to hear you say that, Ruth, because a lot of people know you as, you know, DTTC. That's the way to go completely. And so I like this article because it shows that you're not just jamming one treatment into everybody. Yes, you advocate for DTTC, and that's a lot of your work is in DTTC, but this shows that clinical side and looking at all the evidence and really being a clinician, not just a technician. Someone said that to me the other day, and I was like, I love that, because clinicians, that's what you're doing. There's no recipe. It's not, here's my recipe for how to fix apraxia, and now you go and implement it. That's not how it works. So in your older kid too, Ruth, you, this older one was 15 with residual errors, right? 15, I think.
Right, she's an adolescent.
Yeah, and you used principles of motor learning for that one, yeah. Tried rest, but used, yeah. So, yeah. Anyway, I encourage everyone to check that one out too. Sue Kaspari is a clinician and has significant experience with CAS. And so I think this article is really helpful in just helping you, you know, when you're looking at a kid, deciding what am I going to do and what does the research show. And I appreciate all of you for quality research. I really wanted to do this running through Facebook one day, and I saw Jenya alluded to a therapy approach that is not research-based, but gets a lot of press, like gets a lot of ads. And Ruth would say it's, you know, sexy, but yeah, it's not research-based. So anyway, I appreciate all of you, because this is what is really going to help kids like mine. And, you know, I have an invested interest because it's my daughter, it's my flesh and blood. And yes, now I do specialize in it, and those kids are my kids, but I'm just so grateful to professionals and I always wanted to know why you got into CAS, because, you know, you're so dedicated and committed, and you really are helping these kids by putting out this work. So thank you so much. Did anyone have any final words to say?
One other thing I wanted to say that I didn't is, you know, we tried to emphasize in our article that accountability and collecting data is important too.
Yes.
It's not, be creative in your choices and not bound to a particular recipe, but you need to be showing progress. If there's lack of progress, to be modifying what you're doing, you know.
Thank you for saying that, because I literally just got a message last night that said, what is the data collection protocol for DTTC?
There's a tutorial now.
That's true. That's right. Oh, I forgot to link from Dr. Strand, right?
Yeah, and I don't remember if it's in the tutorial, but the 2016 article too. Well, and in Moss's work, the three-point data collection is pretty much what he's done and what we've done.
Yes.
Or people can email me with questions about that too.
Perfect. Okay, well, I have to cut it because I don't want to get cut off, but thank you so much, seriously, all of you, for doing this. I appreciate it, and I'll talk to you all soon.
Thanks for having us.
Laura.
Bye.